How to ask a question.
Hey guys, it is Jay Campbell and Nelson Vergel and John Crisler. Welcome to the Ultimate TRT Hangout. Guys, how are you today?
Hey,
Good to see you, Jay.
Good to
As
see
always.
okay,
you.
good. Yeah, good to see you. Yeah,
Awesome.
welcome, guys. We're very happy today. We have basically that was Jay's idea, I think. Why don't we get the three of us? We have written books, each one of us on testosterone. Mine was first. Dr.
The
Dr.
pioneer.
John Crisler's was second, and yours third. I guess we're like the three musketeers of testosterone writing. But anyway, so it would be an interesting, he said, it would be interesting to have the three of us and have people ask us questions. So this is a very rare opportunity. We're all friends. Our books kind of pseudo compete with each other, but we cover different things. I think Dr. John obviously is from the doctor's point of view, and Jay is actually a more hip and more formatted, better looking book than mine, but mine was obviously 4 years old, 5 years old, and so it's served its benefits and its time. But today, before we start, I want to, for those of you that don't know who we are, want to each one of us introduce ourselves. Besides writing books on testosterone, I'm the founder of excelmale.com. It's a men's health forum where we answer questions and people ask questions. Dr. John posts questions there a lot. We have other doctors there too. We have over 12,000 members. So feel free to post at excelmale.com. And I'm also founder of discountedlabs.com. It's a lab testing company. You can order lab tests online. Most U.S. cities, we provide a prescription. So I think I have the best prices online for anybody that wants to monitor their health or having their doctors too. You can work with your doctor, obviously. And I'll have Dr. John Crisler introduce himself, but before he does so, he's actually one of those doctors that works in different places. He has a clinic in Lansing, Michigan, and that's where he lives. And he also consults and works, sees patients from Defy Medical. It's a national clinic located in Florida. But Dr. John, go ahead and tell everybody a little bit about yourself.
Hi, everybody. John Crisler D.O. I'm a graduate of the Michigan State University, Go Green, Osteopathic Medical School. I currently serve on the faculty there. I'm a simple country doctor, so if I can figure this stuff out, all the other doctors should be able to. I practice what's come to be known as interventional endocrinology, and I'm just really glad to be here tonight.
Awesome. Well, John, thanks for having us. I'll just jump in, guys. So I'm Jay Campbell. I have a blog. I co-founded a blog with my wife. It's called FabFitOver40.com. It's a very, very influential website for fitness over 40 information. And as Nelson said, I authored a book about 2 months ago called The Definitive Testosterone Replacement Therapy Manual. And honestly, I just stepped on the shoulders of these two giants because both of their books has a lot of my research and information in them. But as Nelson has said before, we all have a little bit of a different and unique angle in the way we wrote them. And all three of them are honestly gold mines. I highly recommend, if you're watching this show right now or even going to be watching in the rerun, that you grab the books. They're very, 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 very cheap on Amazon. All of them are under 20 bucks. And if you want to obviously get the Kindle versions, they're under 10 bucks. So with that said, Nelson, why don't you start us off, and we'll start talking about some of the topics for Dr. Crisler.
Yeah, we have a bunch of topics to cover. And by the way, we have questions that people that have already asked. We have also some Facebook pages. I have a group called Testosterone Replacement Discussion, and there are over 6,000 people there. And Jay has also a group there. So people have been posting. So we have a bunch of questions. But the first topic that we wanted to cover is the use of Clomiphene, clomid therapy, as a way to increase testosterone and or increase fertility for men. There are controversial data on that. I want Dr. Crisler to go into details or give us a 5-minute brief description on how he uses Clomiphene or clomid.
Yeah, well, I could take the 40 minutes just talking about Clomiphene.
Yeah, I know.
A lot of work going on with it right now. It's been traditionally used in fertility medicine because it increases the production of luteinizing hormone and follicle-stimulating hormone, and therefore also produces an increase in the production of testosterone. when they first began producing clomiphene tablets, it was made in a 50 milligram dose. And the reason why the dose is 50 milligrams is because some guys said, why don't we make them in a 50 milligram dose? So that became the standard daily dose of clomiphene. The problem with clomiphene is that half of the pill is actually an estrogen. There's an estrogen blocker called N-clomiphene, and the other half is an estrogen and agonist, actually acts as an estrogen in the body. That's called zooclomiphene. So if you take a 50 milligram tablet of clomiphene, you're actually getting somewhere in the neighborhood of 25 milligrams of estrogen. I think that's where the problem comes in. 8 or 9 years ago, Dr. Eugene Shipp and I sat down and had lunch in a conference in Florida, and he shared with me that he found that 25 milligrams was working even better than 50 milligrams, and I shared with him that I'd found the same thing. He went on to cut it in half again and actually has patients that take 12.5 milligrams every other day of clomiphene. We're finding a lot better results in because there's only so much stimulation you can give the Leydig cells, the testicles, that produce testosterone. So there's only so much testosterone you can produce. But when you go above that, for some strange reason, we get more estrogen and we get more progesterone. Those are both highly feminizing hormones in men. So we're now using 12.5 milligrams per day of clomiphene, and therefore we're only getting about 6 milligrams of estrogen in there with it. The estrogen, I think, is what caused the problems. For the guys who are getting good testosterone levels with clomiphene stimulation at, for instance, 50 milligrams, I think the reason why they don't feel the benefits at that dose is because not only are they producing more estrogen because of the higher testosterone, but part of the clomiphene is actually acting as an estrogen that's adding in. So for that reason, it can elevate their sex hormone binding globulin, and while the sex hormone binding globulin testosterone complex is not inert, we treat it as such for analytical purposes. So the sex hormone binding globulin can go up, so now you've got to produce more and more testosterone in order to get enough testosterone for us to feel. So with a lower dose of clomiphene, you're not getting as much stimulation to elevate sex hormone binding globulin, you're not getting as much estrogen along with it. And also, I would quickly add that lately I've been adding, for instance, guys come in, their testosterone is low, but their estrogen might be mid-range. So they got everything moving in the wrong direction. So for these guys, I'm adding in DIM, diindolylmethylene, and also calcium D-glucarate in order to help metabolize and excrete the estrogens from their body. And they seem to be doing a lot better. So the nice folks at APS, when I'm, for instance, working through Defy, they will compound for me, and Dr. Saya was one that directed me to put all these in the same capsule. We put clomiphene, anastrozole if we need to control estrogen, if it's gone too high, and the DIM, the diindolylmethylene, all in one capsule. And it works really well for the guy once we've set the dose. And it might take us a couple tries to get the dose right for them, but we have a lot of guys being really happy on clomiphene now who are feeling it because they're not getting the estrogenic effects. And I want to share too that my good friend Dr. Mark Gordon is about to release a lot of new data. My review is stuff for him, so he's I've seen the preliminary data. He's getting some really substantial, some really impressive results with a lot of patients. He's using clomiphene. He's using 50 milligrams 3 times a week. He's found even 50 milligrams once per week has a great effect. We're not sure why. We don't know why. We just know what. So we have a lot of work to do in this area. But the idea that you could just take a capsule and stimulate your testosterone, stay away from gels, stay away from shots, and feel awesome. And by the way, serve the natural pathways. My backfilling the pathways strategy that I've used for years and years and years, I think that's why our guys tend to do better. And we try to keep those natural pathways going in. And if they're on testosterone, then we'll add in DHEA. We'll talk about that. Pregnenolone, HCG for almost all my guys, so we can keep the production lines running as naturally as possible, with the ultimate goal of having the guy have a great testosterone levels on testosterone replacement therapy, but it would be almost like his body didn't even know he was on testosterone. So that's where we're shooting.
Let me just ask a question here, because you said a few things that people may or may not understand. But you're saying, first of all, you are saying they feel better, right? So I want to give a little background to people. I have the position, I still do. We argue back and forth. I like to see data. Obviously, you're learning a really interesting thing about low dose clomiphene to increase testosterone blood levels, and also probably even providing less issues with estradiol and all that. So men may feel better. And the reason Dr. John says that is because a lot of men on my site, on excelmail.com, complain that when they start clomiphene, 50 milligrams, sometimes they use 25 milligrams. Haven't seen too many reports from 12.5, to be honest with you. Most of them feel very moody, and they just don't feel, their testosterone goes up. So they look beautiful on paper, but they don't feel sexual, they feel kind of moody. So I've always had this I tend to doubt that clomiphene can do what it's supposed to do. It also improves sperm production. So I'm very curious on what Dr. Crisler is doing. I haven't seen the data. I can't believe he's a friend of mine, so I obviously, when he says that it's working, I believe it, but I'm still obviously want to see that. So I hope that you guys can actually generate that data. Because,
so real quick before you answer, John, so there's some people that are complaining. I'm getting emails that I mean, we have a lot of people online right now, but I guess some people are having struggles. So what I did is I just put a link back on the page where this is being broadcast on YouTube. So if you can't get in for any reason, just click on the link and you can get in. Go ahead, John. Continue with your answer.
Yeah, and one more thing. You mentioned HCG for all your patients. Also the ones on clomiphene?
For some strange reason, it shouldn't work, because HCG is a mimic of luteinizing hormone, and it should suppress. But for some, I think probably, let me say just maybe, it may be because HCG has its own intrinsic benefits. In other words, it directly affects the luteinizing hormone receptors in the body. So I think we're just getting more. I just know that some guys on clomiphene do better if you add a little HCG in. It shouldn't work, but it does. This field is so new; we're just scratching the surface. We have to keep our minds open.
Yeah, and I'm definitely going to be on your back, you and everybody else, to generate that data, because if you guys are really ahead of the game in many ways, and Defy and your clinic, but as I said, we need to move from anecdotal to presenting a conference or two. So I'll be behind, because that's how the world really believes anything. So
well, real quick, John, before you answer, Nelson, I actually echo your sentiments. I mean, I've used clomiphene in the past as well, and of course, John, I used the higher dosage, because 9 or 10 years ago, exactly as you intimated, that was the dosage, right? But, I personally believe that the 12.5 milligrams to 15 milligrams to 25 milligrams, the experimental area, I'm sure there, like you said, the interventional endocrinology aspect of this, there probably are some guys. I know anecdotally, and I know, Nelson, you want to see data, you're an empiricist, but I have heard from some guys that have done really well. I mean, as Nelson knows too, and gets them all the time. I'm getting a lot of emails from guys that started with Defy a couple months ago and said, "Oh my God, they just put me on clomiphene. I feel amazing." I've sent a couple of those emails to John. John's working with these guys, but then I've also heard from guys, as you said, Nelson, and as you and I experienced, sort of just like, my numbers on the paper went up into the 700-800 range, but I didn't feel like I was optimized. I didn't feel.
Yeah, let's substitute 11, 12, 1300, because that's what we're seeing.
Right.
Dr. Saya told me a couple weeks ago he had a guy at 58 years old. Then Dr. Gordon told me last week that he's got a guy at 70 years old that's responding well to clomiphene.
That's awesome.
So what does that mean? It means that we're going to stop giving people injections? I mean, if it is that good, why not just give everybody?
Yeah, wouldn't that be wonderful?
Well, a pharmaceutical company is trying to get that approval, so they've already.
All you get on the boards is a bunch of complaining, and guys are their minds are so set that it's not going to work from the start, because guys are talking smack on the boards. That's the old dosing and so forth.
Okay.
And the guys talking a lot about its positive benefits. Well, I think basically because they get happy and they go off and they're living their lives. They're not, the squeaky wheels are the ones that are still on the boards. I wish guys would stop talking smack about it. It's like everybody's putting down transdermals. Some guy comes in, some guy on board told me that transdermals don't work. Well, I wish some guy wouldn't type that on there, because it's nonsense. Transdermals are wonderful.
Okay, if Clomid works for you at 12.5 or 25 or 50 milligrams, please post your experiences on excelmail.com, because I'm not convinced yet. Anyways, let's move on. This next topic is even more controversial, at least because I'm always fighting with every doctor, including Dr. John, on my point of view here. Estradiol, the dosing of using another aromatase inhibitor on men on testosterone that have good testosterone. They may have symptoms of high estradiol. We'll talk about that, or gynecomastia, which is very rare. And they may have, what is high estradiol? First of all, how do we manage it? What are the symptoms? And then we can discuss on my beliefs on this whole issue. So, Dr. John, why don't you start?
Great topic. Now, by the way, the clomiphene dose at 12.5 milligrams is just a starting dose. We start there and increase if we have to. We want to say that for sure. First place, if they're not having estrogen symptoms, I do not treat. So if a guy comes in, if he's using the Quest Diagnostics ultra-sensitive assay, if he's using the LabCorp sensitive estradiol, or the Mayo Clinic enhanced estradiol, they're called, and he comes in and his level is higher than the top of the normal range, and he has no estrogen symptoms to complain of. For instance, water retention, itchy nipples, aching nipples, excessive moodiness. If he's not been watching Oprah, subscribing to Red Book magazine, buying shoes, expecting guys to know what they're thinking without telling them, things like that, then I don't treat it. I just can't get myself to do that. There are just too many things we don't know about this field of medicine. If a guy has a low sex hormone buying globulin, however, since he'll have more free estrogen, just like he has more free and bioavailable testosterone with low sex hormone buying globulin, he may be really sensitive estrogen. So if he's having estrogen symptoms, I will apply an aromatase inhibitor if he's 2/3 up or 3/4 of the way up in range. I've done that many times before. Everybody is different. You've got to find the sweet spot for all the different hormones. Each hormone has its own sweet spots, in my experience.
Starting dose, what's high? Yeah, to those two questions.
No, yeah, great question. It's really patient specific. I just go by feel, by my 15 years experience of doing this. Some guys get 1/4 milligram of anastrozole every 3rd day. Some guys get, if they're taking 2 shots per week, I might lay in 1/2 milligram of anastrozole on each shot day. That way, when the testosterone comes up, the anastrozole is there to block the conversion to estrogen. Really, they're all different combinations I use. Just got to keep trying to get it right.
John, what's your rule of thumb with body fat levels and AIs?
Well, clearly, the more adipose tissue they have, since the aromatase enzyme lives in high concentrations in the fat, clearly the more fat they have. That's why we demand to run labs every 6 months, also to check a CBC, complete blood count, to make sure they're not developing the erythrocytosis, the red blood cell production is not making their blood too thick, so getting polycythemia. But if a guy goes on testosterone replacement therapy, we see guys losing 20 or 25 pounds in 6 months. That happens all the time. Now, also, he doesn't need aromatase inhibitor anymore. So,
right.
Yeah, and the problem I have with this field, or this part of the field of estradiol management, I have a few issues. First of all, we say most doctors are using the upper number of 40 picograms per milliliter, and obviously we're talking about the sensitive estradiol test, and most clinics are using the old test, the immunoassay, which overestimates because it has an interference with CRP, inflammatory enzyme. But anyways, even if you use the right test, I'm seeing a lot of guys over-treating themselves and bringing their estradiol below 20, which has been shown to affect decreased bone density and actually even sex drive. We need estradiol for sex. We need estradiol for mood. We need estradiol for heart health. So what I'm trying to get at is that the symptoms of high estradiol, water retention, symptoms like even guys think they're having gynecomastia when in really fact they're having nipple sensitivity. Testosterone has been shown to increase nipple sensitivity in some men, which has nothing to do with gynecomastia, which is the increase of the gland size under the nipple. So that could not be related to estradiol. The water retention also. I mean, salt. Some people hold more salt or more water with testosterone. Even people that are using anabolic steroids, DHT-based, steroids that don't aromatize, can cause water retention. So for me, the water retention symptom also could be caused by nothing to do with estradiol. So what I'd like to see, once again, I'm here because I'm used to working in research advocacy in my field of HIV. I always thought about generating ideas for research. I'd like to see a study, which there's not a single one, that gives testosterone replacement to one group of patients, and testosterone replacement plus anastrozole, whatever, low dose, based on the numbers, and measure their sex drive in 8 weeks, their mood, their water retention. That would be the study to see. Nobody has done a study, published a study on healthy men on testosterone replacement taking anastrozole combinations to see. So the only study that has been done is on epilepsy, because these guys have high estradiol and high prolactin due to their medication. So once again, we can probably, I'm thinking we should create like a foundation for men's health research, because all this stuff that I hear, I'm an engineer, so I become obsessed with numbers. There's so many opportunities to show the world that this stuff works, because it works. I can tell it works. I have never taken an anastrozole. I think anastrozole, in my point of view, it's not a drug that most of us need. But I do like to see more information.
Well, if we're going to drill right down into what is going on with, basically the quantum nature of hormones, is that the manner in which you speak of researching this is traditional to epidemiology. And traditional epidemiology, Dr. Shiffman wrote an excellent foreword, graced me with an incredible foreword for my book, where he really, really says it's better than I can. But traditional epidemiology basically tries to compress everyone into a monolithic creature. And so that doesn't work with hormones, because everyone has a different sweet spot. Everyone is different. So rather than trying to analyze a population and find a range or sweet spot for everybody, it's up to the clinician to gain the knowledge and experience and to care enough for each patient individually to analyze them, to figure out their case and figure out what to do for them, because epidemiology falls way short. That's why so-called normal range is such a sick joke with respect to testosterone replacement therapy. Normal range is 300 to 1,000. The guy comes in at 325, and the doctor says, "Well, your normal range. Here's some Viagra. Here's an antidepressant.
Right.
I'll see you in 6 months." And that's wrong. His problem was not a Viagra deficiency. It was not a Paxil deficiency. It's a testosterone deficiency. And as soon as you correct his testosterone level, he's fine. So normal range is found through traditional statistical means of bookending 2 standard deviations. So and since half the guys at the age of 50 have low testosterone, a significant portion of that pool is sick. Now, you wouldn't take a potassium level on a kidney failure patient on the way in for their dialysis treatment and add that to normal range. So why are we adding so many guys who are sick from low testosterone to the so-called normal range? So you have to take your eyes off the piece of paper, because you're not treating ink. You're treating a living, breathing human being, and you have to really take a careful medical history, and then by your knowledge and experience, figure out. I see your kitty sneaking up on you behind there.
Well, one of the, first off, guys, great comments. One other thing I'd add, and it's imperative and extremely crucially important, is that you have to become aware and take ownership of your health as yourself. And again, all 3 of us have written books that can make it a lot easier for you, as an individual guy watching this show, or just out there, you're contemplating TRT or using TRT, because no matter how good the doctor is, as he's saying, this is interventional endocrinology. Every human being is going to be biochemically unique. They're going to have different response mechanisms. It doesn't matter what you put in your body from a chemical standpoint, whether you're using an AI or you're using a different testosterone delivery system. Everyone is going to respond differently. And if you don't understand what's happening to you when stuff does happen, you can't just, arbitrarily rely on your doctor, who has another 500 to 1,000 to 600 whatever patients that they're also working with, to be able to read your mind. So again, for all of you guys that are doing this stuff, take ownership of your health. Read our books, understand what's going on, and then once you have a good semblance of understanding of what you're doing, that's when you then communicate with your physician and say, "Hey, doc, maybe I should consider this." I will say this: if you work with Defy, and Nelson and I know other doctors that are great too, they're really good people. They're not God complex doctors that are going to stand there and say, "I'm the doctor. Who the hell are you? I'm not listening to you." They're really not.
Sometimes I do.
Very, very
I didn't want to say anything.
If you're intelligent, very rarely, and you're taking ownership of your own health, and you know what you're asking, you know what's going on, you have a good understanding of, this is what's been going on for the last couple of years, believe me, they're going to listen to you.
Yeah, well, sometimes. But, my issue, and this is me going back, I'm not the devil's advocate, but, I come from a world of a lot of data. So obviously I'm that guy that gets on doctors' nerves, like Dr. John says. Yes, everybody's different, but there are ways to prove that something can be predicted at a level where we have a baseline population that are pretty similar. That can be proven. It's in fact proven for testosterone. So we did studies for testosterone. So insurance companies now pay for testosterone replacement. Because we have data on that, and pharmaceutical companies. No insurance companies are paying for an anastrozole. Why? Because we don't have the data for insurance companies to say, yes, it works for that purpose. No insurance companies are paying for HCG for TRT use. Because why? Because we're trying to have data, but I guess we haven't really advocated for the data that much. So what I'm trying to say, the need for data is not because I doubt that things may work or not, because I'm actually in the field. I've been in the field for 30 years, so I see how things work. Is how I would like for the average American to have enough access beyond cash. I mean, we have our BFI and mid clinics are cash-based. They're great because they give good prices, I have to say. I've been in the field too. But it is most guys that I get emails from have insurance and obviously are having difficulty accessing these other medications that go with testosterone. So anyways, that's just my opinion on data. So let's move on because we have a lot to cover. The Finasteride syndrome, which Dr. John has a great video on YouTube. He's being a pioneer on this syndrome. I'd like for Dr. John to explain, first of all, what finasteride is, what it's used for, what is this syndrome, is this something made up, or is this something, because I've also heard people say, well, it's controversial, and how you treat it, and just history on the whole thing. Thank you.
I think Jerry Brainham had a question on that, didn't he?
Yeah.
Jay, what's the question that Jerry asked?
Yeah, I can answer
that right now. Can you?
Yeah, of course.
That covers everything right there.
So his question is, I'll just read it very fast. What is the precise mechanism whereby finasteride can cause sexual function problems? Since finasteride lowers only 60% of DHT and only one of the two 5-alpha reductase enzymes, why would any problems arise since you still have at least 40% of DHT production? Also, since not all men who use finasteride have any serious side effects, could it be an idiosyncratic reaction, perhaps due to a lack of sufficient testosterone or allopregnolone produced by these men?
Okay, excellent question.
Yeah.
Well, I'm not sure about the 60% number. Basically, 5-alpha reductase inhibitors like finasteride, dutasteride, Propecia, and Abidart by their trade name.
Proscar, yeah.
Yeah, and Proscar, when it's used for the prostate, they just cut it into pieces. They inhibit the conversion of testosterone to DHT. DHT is a strong androgen. It's 3 times stronger than testosterone. The problem is that we're prescribing it for men to save their hair, and putting it in your mouth to save your hair is like trying to fill a teacup in a thunderstorm. So now I'm doing some things. I only use topicals. I've never prescribed finasteride. I use topicals, and now I'm actually putting some finasteride into the scalp lotions in order to stop the hair loss and regrow hair, along with the other things we do. And there's no systemic absorption. So, anyways. So you put it in your mouth, and it lowers the DHT for your entire body just because you want to save your hair. Well, the problem then is that DHT is responsible for all things male. By the way, my website, I should have said earlier, is www.allthingsmale.com. Why certain men are susceptible to the dreaded post-finasteride syndrome, we don't know. I can tell you that they're more likely to have low sex hormone binding globulin levels. I can tell you that a fair number of them come in. I have the wonderful news for them that they don't actually have post-finasteride syndrome. This fits right into Jerry's question. They're a guy who had normal testosterone levels. He was lowering his DHT with finasteride. Then when his testosterone levels dropped for whatever reason, now his DHT goes right in the toilet. So that brings incredible negative changes in life. Fatigue, depression, sexual dysfunction, weakness, paresthesias, on and on and on. It's actually a global malady for the guy, and basically all we really need to do is put him on testosterone replacement therapy, get him off of finasteride, put the finasteride directly on top of his head instead of in his mouth, and they're fine. Of course, I'm delighted to tell them that they have low testosterone because the prognosis is so much better. We've had several suicides from the group. This is not a joke. This is a very real malady. Like adrenal fatigue is a very real malady, and finally it's being recognized. Unfortunately, through the success of some lawsuits against Merck. So the effects have to do with some demyelination, have to do with lowering the allopregnolone levels in brain, which is directly related to anxiety. That's why I use pregnenolone in these guys. I try to use Clomiphene. I have about a half dozen different therapies that I try depending on the patient. And if necessary, we tend to put them on testosterone replacement therapy. And it seems like it takes a little higher doses to get them feeling right. But I've seen some guys who've been really, really messed up from it. It's not funny, and I think we should be all getting together to work on it a little bit harder.
So, Dr. Crisler, is it, do they just have lower DHT, or is it a receptor thing? Do you try to increase the DHT? Some doctors are using scrotal testosterone creams, and once you put on your testicles, because that tissue actually converts more into testosterone into DHT.
You bet. Mm-hmm. All the guys, if I can, I get a 24-hour urine panel from Ryan Consulting Laboratories in Portland, Oregon. Mm-hmm. That gives me about 30 different hormones in that 24-hour urine panel. So it's all they produce in a day. It's the best lab in the country, without a doubt. The THF to 5-alpha THF, which basically is like testosterone to 5-alpha converted THF. To 5-alpha THF, I'm sorry, that gives me an understanding, appreciation for the activity of the aromatase, of the 5-alpha reductase enzyme inside the cells. So I start with that. A lot of times these guys are just not making DHT very well anymore. There seems to be some epigenetic effect. Some guys are just all set to break, and some of them have been broken by the very first dose of the Finasteride. So we have a lot of work to do. In the meantime, we're just trying to figure out what to do to make them feel better until we can get it all figured out. But we have pretty good success with the cases. Really, we're doing a lot better. There are about half dozen of us that work out and compare notes, and I think the future looks much brighter for those poor fellows.
Yeah, I took Propecia in my 20s, and I have to say it really affected me. I think looking back, obviously back then we didn't know what we know now. And looking back, I can say that's probably where a lot of my problems started. Of course, I lost hair anyways, but I'm keeping it. Actually, I wanted to bring that up. If you guys want to use Dr. Crisler and Defy and compounding pharmacies make creams, hair gels with some blockers. Some people use ketoconazole. I used to have a gel. Ketoconazole is like Nisorol, like the Nisorol shampoo. I actually have a bunch of stuff next to me.
You carry your shampoo around with you, dude?
No, hey, guys, somebody asked me, Nelson, can you show stuff on this that you use on the screen, So I'm not selling Nisorol, but Nisorol is ketoconazole. I want to use that. Yeah, you have to use, so I use one. I also use Rogaine generic, the foam, because, my hair hasn't fallen in the past 6 years, and I lost a lot of it before that, obviously. What else do I use? That's it, really, for hair. So you can use topical products, guys. You don't have to take this pill.
Shave your head.
I'd love to take a trip through your medicine cabinet.
Oh, my God. Oh, man, I have like...
All right, so John, so real quick then, on the oral Finasteride, obviously we just heard from Nelson. I mean, so for guys out there that are on it right now, what do you recommend?
Get off it.
Like cold turkey it? Literally no taper, cold turkey.
Taper down. There's a long half-life on the metabolites. So
yeah.
And the problem is, guys, they can be on it for a while, then all of a sudden they develop the post-Finasteride syndrome, even though their testosterone levels are high. Those are the worst cases. Those are the scariest cases for me if they got good testosterone levels and the post-Finasteride syndrome.
Yeah, Dr. Crisler, but those that have BPH, the prostatic enlargement, that's when we have to be more careful. Obviously, they can probably use low-dose Cialis, daily Cialis instead.
Yeah, Cialis is wonderful. I love Cialis, but I've been shrinking prostates for years by controlling estrogen. I can pretty much tell what a guy's estrogen levels are when I feel his prostate.
Really?
If you metabolize estrogen properly, it's estrogen working in an environment of DHT is a problem. So if you control the estrogen, everybody knows estradiol increases the stromal proliferation in the prostate. Estrogen makes prostates hard instead of rubbery. Soft and rubbery, I should say. So I can pretty much tell what's going on with hormones just by physical exam.
Wow, that's a big claim. I'm going to have to need a reference on that because I've read everything of it. There's some receptor issues, but I've never heard that one before. But anyways, I'm not like I'm
breaking new science on you, Nelson.
I'm the guy that just doubts everything because that's what I do.
Good.
Let's move on. Let's move on. That's another hot topic. HCG, benefits beyond testicles. Once again, Dr. John, you start, and then obviously I'm the doubter, so I usually doubt after you.
Okay. Well, there are luteinizing hormone receptors all over the body. So the pituitary gland makes luteinizing hormone. It goes through the bloodstream. When it gets to testicles, it stimulates the Leydig cells, produce testosterone. Helps keep them up to size, though everybody's different. But there are luteinizing hormone receptors all over the body, and they would not be there if they wouldn't do something. And we know that luteinizing hormone stimulates the conversion of cholesterol to pregnenolone in pathways all over the body. So many years ago, working with steroid athletes, as you know, I've never prescribed steroids, but I help guys, or I do PCT and try to help maintain their health along the way.
What's PCT?
What's that?
What's PCT?
Yeah.
Psychotherapy. Thank you.
Okay.
So I started using low-dose HCG every day. You know, I started out at 100 units a day, and the guys, basically to a man, told me they felt better. They didn't get that edgy, burned-out feeling in the middle of the cycle that we know about. So I knew it was doing something, and I just carried that on, extended that into testosterone replacement therapy. So I want all my guys on testosterone replacement therapy, if they're taking testosterone, to be on HCG as well. Some guys do very well on just HCG, and Dr. Shippen's done a lot of work in that area. But HCG is wonderful. It affects the emotional centers of the brain, the more peripheral centers. It brings a sense of well-being. It brings a sense of libido. So I have the guys start out at 100 or 150 units, and I have them take it in the morning. And then when I talk to them again, I want to find out if they feel that shot or not. Because I didn't feel the HCG, I wanted to take a little bit more. Because you should be able to feel the HCG if you take it in the morning. It's more physiologic to take it at night, because that's when you're used to having a luteinizing hormone surge as you sleep. But I figure go ahead and take it in the morning, and then it'll help you through your day.
Okay, just to give people a background on HCG, the doctor went into detail, but HCG is a luteinizing hormone mimicker. It's actually extracted from women's urine. Pregnant women produce it, spike it while they get pregnant. That's how actually the pregnancy test is a test for HCG. But anyway,
it kills a rabbit, as we know.
I know, right? Kills the rabbit. But it actually stimulates the cells in the testicles to produce testosterone. The interesting thing, and what got me really interested in HCG, besides obviously is known to improve testicle size once we use testosterone for a while. If you use it by itself, some guys may have testicular atrophy, which you know, in some cases it's not only cosmetic, but when you're having sex, your testicles can actually recede into your body, and many guys don't even tell their doctors that is hurting sometimes. So I had that problem. I've been on testosterone for 25 years, and back in the days we didn't know much about HCG, and I did have testicular atrophy, and that was my problem. So there is a pain-related issue. Some people say, how do I get my doctor to listen to me about HCG? Because he says, well, that's a cosmetic issue. You know, you don't need. Although you can say, well, my testicles have shrunk to the point that it hurts. When you say hurts, that actually can get you a prescription. Secondly, we started seeing good data from Baylor College of Medicine here in Houston. Dr. Lipschultz did a study in which he combined HCG 3 times a week, 500 IUs, with testosterone. Some guys were on testosterone gels, some guys were on injections, so it really varied. And to see if their fertility would improve. The matter is that testosterone shuts down your sperm production. Some guys actually retain some, but some guys don't have any, and they can get their girls pregnant. So Lipschultz did a study in which he gave the combination of the two, and he saw the sperm count and quality increase dramatically. So that was a very encouraging thing. But after that, and nobody has really, that's another one of my pet peeves, nobody has done a study, and I'm trying to push Dr. Lipschultz to go back into that study and pull data on sexual function. So I really believe, and this is my true belief, that testosterone used with HCG, testosterone, you can inject testosterone once or twice a week, 50 milligrams twice a week, and HCG also twice a week in many cases. I actually do have my own protocol that some people like. Some people say I'm doing something wrong. Is in combining the HCG with the testosterone in the same syringe, injecting it twice a week on my deltoids. But anyways, what I have found personally, and many of my friends, is that your libido really improves dramatically. Not only your testicles get fuller, your libido, even your mood. So I've been, like Dr. Crisler was saying, I've been very curious about what else is HCG doing beyond Leydig cells volumization. So we're finding out that the brain has LH receptors. You know, we're finding out. So there must be something else HCG is doing by mimicking that LH. So anyways, very, very exciting. I think HCG with the combination of testosterone can ensure that somebody can remain fertile and trying to prepare. But my question to you is, now that beyond. I'm sorry, Jay, if I don't want to jump. But for instance, if we use testosterone and HCG, you have good sex drive, fertility goes up. What's the difference for you on deciding who to put on clomiphene? You know, they want to remain fertile. And who to put on testosterone plus HCG for the same end result. It's fertility, sex drive.
Well, hold on, John, before you answer that, I'll just jump in real quick because I'll give my own personal. So
Yeah.
I had both of my children between 37 and 38, and I was on testosterone and very intermittently HCG. Now, I am not like Nelson. I do not use HCG. I do not use an AI. I use a very low dose of testosterone, have been for 15 years. There's been very little deviation. I'm one of the lucky people. I have a very strong libido, which I think, and so I'm one of the. I'm kind of an outlier, but
I live in Vegas. I know.
I am an outlier though, because I do believe, as Nelson says, that most men, and I know Dr. Osborne and Dr. Crisler, he already admitted it. That's the way they prescribe. You know, they prescribe it concomitantly with testosterone and HCG together. But I'll let you answer the question, John. But I think it does come back to kind of the biochemical individuality of people, with this stuff. Go ahead, John.
What was the question again?
The question is, you have, let's say, a patient, 38 years old, low T, low testosterone, low sex drive, and low sperm, wants to remain fertile. Which one? How would you decide whether that guy should do testosterone plus HCG or clomiphene plus everything else that you mentioned before?
Well, at 38 years old, he's a Clomid player first.
38.
If we can restore his system, the system is very, very dynamic and very plastic still. And if we can use clomiphene, a lot of times we can just stimulate their system and they'll keep up and running. You stimulate the hypothalamic impulse driver, and away he goes, and you push it up, and it stays up, and he's off for another 10 or 12 or 15 years. But anybody that's under 50, I really consider clomiphene. And I have lots of guys over 50 on clomiphene doing really, really well. Again, the problem is because they come in and the guys talk smack on the boards about it, and they're all just convinced it's not going to work, and you can't hardly get them to start on it. And some of the guys are pretending that's not working when it is because they want to get jacked up, and then basically that's a problem for me. But if we can get stimulate our own system, it's going to be a lot better. We're going to find out as we age. I think these things are going to make a big difference. The more we stay to the normal pattern, normal hormonal landscape, the better off we'll be.
Yeah, so it is age-related, your decision to go to Clomid, or how about if the guy was 48 years old?
That's part of it. I've had parents bring 20 and 21-year-old kids to me.
Yeah, and for those, obviously, you use Clomid. I get it. Younger age.
I have put them on testosterone that young before. Their system just simply was not. And there are some things you got to do. Be careful when you're maturing a young body.
Yeah, of course.
I put 20-year-olds on testosterone after we exhausted everything else, all other methodologies. So we've got to do on a patient-by-patient basis.
Right.
Yeah, but an older middle-aged man. Let's talk about older middle-aged man. Which you would how do you decide at that point when the testosterone comes back low? How do you decide which first-line therapy to use?
What does his luteinizing hormone look like?
Okay. It's let's say it's a testicular basically function issue. It's a high LH, high FSH, low T.
Well, there's no point in putting him on clomiphene if his luteinizing hormone is already high, because that's a primary failure then. It doesn't matter. You overdrive. I would still use HCG though, because even in case of primary testicular failure, the HCG will still stimulate the luteinizing hormone receptors elsewhere in the body. You guys get great benefit from it. It's all about balancing the hormones.
Good. I see. That's the answer. Okay, the LH. All right. Anything else on HCG we haven't covered, Jay?
I think it's a good question. I mean, again, it's just the whole interventional endocrinology aspect. Everybody's different. Everybody's got to watch and take control of their health in addition to what their doctor's doing.
My pal Dr. Mark Gordon's the one that came up with that phrase, interventional endocrinology, by the way. I just love it. I think we should spread it. I think it really describes what we're trying to do and really moves us forward.
Okay, so yeah, we asked that question here. So we have one more thing, actually two, but thyroid. Let's talk a little bit about thyroid management. Before we start this, I want to share a story that happened in my life just basically the past 4 months. I have a friend that is getting tired. He was on testosterone, with testosterone of 750, 850, doing fine. Testosterone for 10 years or so. Still feeling lately tired, gaining a little weight, getting cold easily. He goes, I tell him, go and get your, tell your doctor to look into your TSH and your thyroid. The only thing that they run was TSH, obviously, thyroid stimulating hormone, which, as you well know, it's what most doctors use, okay? Most general practitioners use. And his TSH came back at 3.7, okay? And obviously, the range supposedly is from anywhere from like 0.5 to 4.5 or so in the United States. I've read, obviously, that anything above even 2.5 to 3, there is something suspect, especially if you have symptoms. So I tell him, listen, yeah, my doctor said I was okay. I don't have a thyroid issue. Says, listen, I really think you should go deeper into that. So he used discounted labs because his doctor would refuse to run a more comprehensive thyroid panel, and he got free T3, free T4, and antibodies, thyroid antibodies. Well, it came back, his results, and his antibodies were through the roof. So his immune system was actually already attacking the thyroid gland, which is called Hashimoto's. It's an autoimmune disease that probably even 20% of Americans have, and they don't even know it. They're getting fatter, they're cold hands, cold feet. I actually got immersed in that after finding out that he had Hashimoto's. Obviously, he's now on thyroid medication, plus testosterone, feeling great. He's burned all that fat. Actually, has to turn the AC on more than he used to because he's a little warmer than he used to. So, amazing story, just happened in my life. I'm not a thyroid guy, but I was able to help my friend just because I knew TSH is not a great indicator, especially if you have symptoms of low thyroid. So, Dr. John, what is low thyroid, symptoms, etc.?
Well, monitoring thyroid with TSH would be like monitoring testosterone with a luteinizing hormone. It just doesn't make much sense. It doesn't tell the whole picture because the body may not be producing enough TSH. That's a type of hypothyroidism. What you described there is a Hashimoto's thyroiditis, which is where the body, and we're ramping up our immune system. All the insults to our body, all the terrible things we do ourselves, ramps up the inflammatory process. We attack our bodies more. And so basically is attacking the little cells in the thyroid, and they burst and they release thyroid hormone into the bloodstream, so you can have these little thyroid storms now and again, which can be a problem when you're treating it. Especially if you want to use iodine. Yes, I use iodine in all my thyroid patients. If there are going to be issues, we can handle it. Everybody needs iodine. If you're iodine deficient along with thyroid, you're washing the baby out with the bathwater. To treat the antibodies, we can slow them down using selenium. Now, most multivitamins have 200 micrograms, and so you take that in the morning, whatever, but I have them add another 200 micrograms later in the day of selenium, or a handful of Brazil nuts are wonderful. So we take about 400 micrograms of selenium, and we follow selenium. Range goes to, I think, 140 on selenium. You can get up to about 700 before you really have problems with too much selenium. The selenium will really calm down the antibodies, TPO antibodies. I've seen guys go from several hundred down to normal range on selenium before, so that's wonderful. We want to get a TSH, we want to get a free T4, which is the major hormone that the thyroid gland produces. We also want to get a free T3. We use the free levels there like we use the free levels for testosterone because it gives us the amount that we have right down where the rubber hits the road for us to use. So also the free T4 to free T3, I hate to use the word ratio, but the relationship between the two tells me a lot about how healthy the guy is, because if he's not converting T4 or T3 very well, T4 is synthroid, T3 is cytomel, if he's not converting T4 or T3 very well, he has issues that we can address to increase the conversion of T4 or T3. This is an all-day subject. We're just really surface right now, but basically the panel you want is a TSH, a free T4, and a free T3. Sometimes I also run a reverse T3, because reverse T3 blocks T3 from working and tends to slow the body down. If you have the symptoms of hypothyroidism, you probably have hypothyroidism. And so number one would be cold hands and cold feet. So if you're always cold when other people are not, that's something we need to look at. Carly, my assistant and girlfriend, has low thyroid, and she has 4% body fat. She's an elite runner. She's absolutely ripped. But she has hypothyroidism. She's always cold, and so we've got her iodine warming her up. We're going to put her on thyroid. There's an example. You don't have to be overweight to have hypothyroid. It really is about fatigue. It's about having cold hands and cold feet. Again, treat the patient.
Yes.
And we must be open to using T4 and T3 because the patient is not converting T4 or T3 well. I don't care what anybody says. If you're not converting T4 or T3, you're still hypothyroid no matter how high your T4 is. That's just the way the body works. It's right in Harrison's internal medicine. So find a doctor who knows what they're doing.
Oh yeah, oh yeah. It's so you know, people complain of how bad some guys have it with testosterone replacement therapy and doctors not knowing how to manage it. But I have to say, on thyroid, I've seen even worse cases of mismanagement. So maybe next time we can actually have a thyroid specific hangout, because it is something that I really think a lot of people are walking around not knowing they have low thyroid, and especially the guys that optimize the testosterone, they still have some symptoms, and the doctors missed, because some doctors run TSH at baseline for all testosterone replacement patients that come for testosterone replacement, but they don't go deeper than TSH. So, anyways, we can do that, and I think that's typical protocols that you use. Somebody asked that. That's actually a pretty open-ended question. Protocols for what? Let me ask, there are more questions here, hold on. Yeah, in case that we add HCG for age management purposes, do we have to supply thyroxine or any thyroid medication if someone suffers from BPH? Androgen, you know, no. That's a strange question. Sorry, let me read another one. Can someone use SERMs instead of exogenous testosterone replacement therapy?
That selective estrogen receptor modulators, that's Clomiphene. That's what we've been talking about.
Is tamoxifen a better choice?
Is what?
Tamoxifen.
No. Maybe it's just because I'm a creature of habit, but I like Clomiphene.
Yeah, I've seen data on tamoxifen on that actually decreases IGF-1.
Yeah.
So, and I saw data actually 6 months ago that reviewed gynecomastia cases in adolescents, and they basically had T to E ratios that were normal. It was their IGF-1 that was high. So this study actually said that IGF-1 has a big role in gynecomastia. So that's probably why tamoxifen also is so effective for gyno.
Now you've done it. Now you've brought up a T to E ratio thing.
No, we're not gonna go there, because we'll be arguing for a long time. Dr. John, we argue a lot in friendly ways, actually. I love you, Dr. John.
You've only been good for just so long.
Well, actually, Nelson, just to piggyback off that, then, John, what is, you know, and I don't know if this is even a question. We have so many of them. We'll get to them. We have enough time. But what is your preferred form of therapy for gynecomastia?
I use tamoxifen. I'll put them on, I don't like to give more than 20 milligrams at a time, so I give 20 milligrams twice a day until those symptoms go away, and then I start tapering it down. Every week I cut it down to 30 to 20 to 10 and then off.
So when a guy has glandular, as you and I discussed when we saw each other at A4M, when a guy has a glandular growth, and I think a lot of guys who are on TRT for a long time, you know, eventually or inevitably develop something. What is your recommendation for surgery? Like, how do you determine when someone needs surgery or doesn't?
Guys think it looks worse than it does, you know, because they're looking down time, they're playing with it all the time. So, you know, if it's bothering you, go to a surgeon and find a surgeon who's done a bunch of them and make sure they take all the gland out.
Yeah. And do it nicely so that you hardly see any scar.
So for a guy then that doesn't, you know, myself, but for a guy, and there's tons of guys out there like this, so for a guy that has, you know, who's been on TRT for 10 plus years, whatever, different delivery systems, and has it in one nipple, and feels like he should have the surgery after he gets the consult, should he have the gland removed in the other one as a preventative measure or no?
If you can get a 2-for-1 deal, I would, but
I would too.
Bogo?
Okay, there's a question here on testosterone replacement and its effect on thyroid function. Do you see, you know, because I've seen some data on some data that testosterone replacement or improved testosterone can actually improve thyroid uptake, hormone uptake. What's any experience, Dr. John?
Everybody knows that the thyroid basically is the thermostat for the entire body. And a man's body runs on testosterone. That's the gas in the tank. So the two of them work together. In the words of the late, great Dr. Alan Mintz, it's a symphony of hormones. So I would probably address, unless there's something really blatant about the thyroid going on, I would address the testosterone first. If the patient, by the way, I treat females for thyroid and adrenal issues as well, because more women have it than men. But if their sex hormones are tuned up and they're still cold, it's a thyroid problem, and we need to dig into that.
Another question on DHEA. How do we use it? I
love DHEA.
Talking to you last week, you have something you're trying on with DHEA. What do you think about DHEA? I'll have my own opinions too. So
I love DHEA. The more I get into it, the more impressed I am by it. The easiest and cheapest but worst way to take it is 25 milligrams twice a day. You have to take it twice a day because of the short half-life. And the dose you take at dinner time will help you make more growth hormone while you're sleeping. That usually gets the guys taking it twice a day. But it by first pass effect pass through the liver and is converted easily to estrogen in men. When men take too much DHEA, it turns into estrogen. When women take too much DHEA for some reason, it turns into testosterone. That has to do with the differences between adrenal production and testicular production. But anyways, a better way to take the DHEA, and this is why I love it, I've got a lot of DeFi patients on it, is using a troche, which is a soft lozenge you put underneath your tongue. And so you get some absorption sublingually, like nitroglycerin tablets for the cardiac patients. I tell you, when I put a DHEA troche in my tongue, I really get a boost from it. I can really feel it. I like it very much. DHEA is very important for cognitive function, immune function, cardiovascular health, but also it's mostly closely associated with sexual function, any hormone. And that's very interesting because as far as I know, I think the only receptors we found line the cardiovascular system. So it's a bit of a mystery at this point, but again, we don't need to know why now, just what. And then you can also use DHEA as a transdermal, which is wonderful because it absorbs in the subdermal layer and then gives a nice distribution throughout the day without big peaks. That's less likely to actually produce estrogen than any of the other methodologies. So for myself, I've been experimenting now with injectable DHEA. I had the idea and talked to Jason Bruce from Defy about it, and he told me that APS was already making it. A testosterone cypionate with DHEA in it, and they had a mixture that's prepared at 100 milligrams. I talked to Sean Nurian from Power Pharmacy the other day about this. He said that testosterone was already supersaturated at 200 milligrams per milliliter of oil, so you really can't get any DHEA into it. So he said the practical upper limit is 100 milligrams of testosterone cypionate with 25 milligrams of DHEA will go in. So that's what I got. My first injection was 100 milligrams of testosterone with 25 milligrams of DHEA, and man, did I ever feel it.
In the same vial?
Yes, in the same mixture.
How many milligrams and how frequently?
Well, it was 100 milligrams of testosterone with 25 milligrams of DHEA. I was just guessing at the dose to start out with, and that was 25 milligrams of DHEA all at once is too much for me. I got side effects from it.
So what dose is the one that you like?
Well, first I'll tell you the side effects. The first side effect that I noticed is hypersexuality.
Oh, come on. I'm going to have to try this to see if it really works.
Hypersexual.
Hypersexual.
What does that mean, actually?
It means that 3 times a day is not enough.
You're going to get a lot of calls from this. I'm trying this next week. I don't know about you, Jay.
Yeah, you better be sending me that shit in the mail, bro.
I took it orally, and I have to say I got itchy. I did not like DHEA. My DHEA level's actually high.
So you're saying it's a massive difference than oral?
You're going to have to.
No. Yeah. But it causes it. I really am chasing estrogen, and this is against it. We thought that, as I said a minute ago, it's the old thought that DHEA first pass through the liver. Everything you eat has to go through your liver before it gets to the bloodstream. So it's first pass effect, and that's very important for everything that we eat and all the medications that we take.
Right.
So I thought there was that first pass, but not. DHEA injectable causes a huge increase in estrogen because it made my chest just ache on both sides. So I started having to take 1 milligram a day of Arimidex to cover the estrogen from a 25 milligram dose of DHEA, which lasted for several days. So then I cut it down all the way down to 25 milligrams of testosterone. Now we're down to about 6 milligrams of DHEA, and the hypersexuality continues.
25 plus 6. Okay, so okay, all right. Well,
so no sensitivity though.
Oh yeah. Oh yeah, and some water weight gain, and I mean I gained like 5 pounds of water, so I washed it out with some Arimidex. And
Uh-huh.
the reason why I wanted to talk about this tonight is I like other people to maybe to start working with it. APS Pharmacy makes it, Empower Pharmacy from Houston makes it. They're all ready to go. And I'd like guys to start messing around a little bit so we can get some feedback on it. We got to get some players going here so we can hear the stories.
There you go, Nelson.
So wait a minute. So 25 and 6, if that's the ratio and that's the dose that you found for you, obviously everybody's different. So that would mean that to do 100 milligrams a week, which is an okay dose for TRT, you would have to inject 4 times of this combo. I guess we'll have to talk about optimizing that, because 4 times I am not injecting 4 times.
I just started playing around with stuff. I've been playing with it for a couple of weeks now, but I'm really impressed. So I have a lot more to go with it, but this is just my initial work. I'm trying to be like Jonathan Wright. Dr. Wright will just announce when he's got something he's working on. He'll spread it out. People start working with it, and then the feedback comes in. And that's how he pushes the field forward.
Yeah, I'll try a few ratios and let you know. 'Cause that sounds great.
Well, Dr. Ruzzi is using in some of his patients. He told me he's using, and I have the ultimate respect for Neil Ruzzi. He's a great guy and a brilliant doctor. He's using 200 milligrams a week of testosterone in some of his patients in very small daily doses. And so if you're adding a little bit of DHEA along the way, that's what I was thinking of. A little bit of DHEA along the way would be a wonderful thing. I have taken no oral DHEA since, and my sense of well-being is through the roof. This stuff is truly wonderful.
Good. I don't like injecting more than twice a week, and he also doesn't believe in estradiol management, so I don't quite believe everything he says. But anyways,
that's the conversation I've had.
He's actually agree with him on estradiol.
When I told Shippen what Ruzzi said, he blew a gasket.
Hey, do you want to talk, because some guys are asking about sermorelin and peptides, but sermorelin is the only peptide that is U.S. approved, right, in the U.S.? Or you want to cover that, or should we just entertain other questions? Maybe
you want to talk about peptides at all, John? I mean, I don't know if we really need to.
I don't think so. Sermorelin is the only one, and all the other ones are just...
I will share something with you, is that at Defy, we are just coming to agreement. We're going to be offering the 24-hour growth hormone assay, which is the only valid way. The assay comes from a Belgian company. It's the only assay that I consider valid for growth hormone status determination. So a 24-hour growth hormone, we're going to be offering that for our patients through Ryan Consulting Laboratories. And this is the way to find out how much growth hormone produces.
How much does that cost? How much does that test cost?
Don't have numbers yet. We're in the initial stages. We just came to agreement with Defy today with Dr. Sy and Jason Bruce to implement the protocol. So we're still getting online, but.
So I'm assuming that's urine.
Urine, 24 hours.
Right.
Yeah, but would that get you a prescription of growth hormone? I don't think so.
No.
But anyways,
not from insurance. We're not using it for. We can't work with growth hormone anyway.
Yeah.
The regulatory.
So why would you use that test?
Well, for the guys to find if they're truly deficient, and also the guys using sermorelin, and also some people are on peptides when they come in, and we just test them and follow them for them to try to. For instance, I always want to get an IGF binding protein 3 to make sure they're not increasing their cancer risk and so forth. Sometimes guys come in wanting to know what their growth hormone status is, and they find out that they have a low IGF binding protein 3, so we elevate it with quercetin. So he came in looking for growth hormone status information. He walked out with a greatly decreased risk of cancer.
I'm not a horrible believer in peptides or sermorelin, to be honest with you. I've seen, especially if you follow IGF-1s, I don't see races, and they're expensive.
IGF-1 is reliable in average people, but our guys are not average people.
Yeah, we did a study on peptides in HIV, and we only got 1-inch loss of waist circumference after 26 weeks of daily injections of 2 milligrams of tesamorelin, which is a little longer molecule than sermorelin. Right. And obviously, when the guys stopped, the fat went back up, and it's just too much work for
the only thing that I've seen, like, again, empirical, there's no data, as we know. I mean, most of the peptides that are sold out there in people's basements. But I've seen ipamorelin work well with women. And again, it's empirical. But I'm with you, Nelson. I don't see any value in it at all.
For the amount of money.
No.
Any other questions? Is anybody asking questions, or do you have anything else? We're basically at 1 hour and 4 minutes. I don't know about you guys, but I'm very happy with this discussion. We've had a really friendly chat. Dr. John hasn't gotten mad at me for doubting so much, so I really appreciate that. So,
I love it, man.
There are some more questions actually. So let me just throw them in there real quick.
Okay.
I don't know how valid this question is, but Dr. John, Nelson, you guys can both jump in. What factors determine rational cessation of testosterone replacement therapy?
PSA, I guess, but even then, what do you think, Dr. John? High PSA?
Currently, prostate cancer is a contraindication, as is breast cancer. I wonder if they're talking about going off it or trying a trial of abstinence.
Or going off of it, what would be the clinical situation that required for somebody to go off? What doctors are doing is that they're getting guys off testosterone to make them get their wives pregnant, which is the dumbest thing to do, to restart their production of sperm. It's the stupidest thing to do. You can add HCG to it, to TRT, and actually get your or Clomiphene
too. Yeah. It's fun.
But not stop your TRT. How are you going to have sex if you have no sex drive? So
the problem is then they quit practicing.
So what, high PSA. What else would require? Some doctors also. Listen to this. They're stopping TRT, testosterone replacement, because hematocrit goes up. It's the main side effect of testosterone. Everybody should know that hematocrit, which is the amount of red blood cells in the blood, goes up. That's a normal thing of testosterone. If you have an excessive hematocrit, you just go and donate blood, or have a doctor write you an order every 3-4 months.
So send them down to the Red Cross.
Yeah.
Right. So, gotta get them down there soon. Keep them hydrated. Give them an aspirin to make sure nothing happens in the meantime. We don't like the hemoglobin to go above 18 or the hematocrit to go above 55. That means we withhold testosterone replacement therapy. By the way, if you go to the Red Cross at lunchtime, you can probably get a sandwich. That helps.
And if you get rejected because there are many people like me, my blood is toxic waste, you can get an order from the doctor or a script and get it.
Yeah, we do therapy phlebotomies. That's a real hassle. It's a lot of paperwork nonsense. I just want you to be able to go to the Red Cross. You gotta get them right down there to do that.
It's amazing.
It's a good thing for your health to dump iron out of your body, anyways.
Hey, so a couple more questions, John. Sub-Q. So this guy said sub-Q injections, are they superior in your opinion to once or twice a week injections on testosterone for a person 50 or up?
Probably 95% of my guys that I switch to sub-Q love it. It seems to increase libido. It doesn't hurt. Think about it. If you're taking if you have low sex hormone binding globulin, you've got to go to more than one shot per week.
Right.
And then think about it. If you're taking 2 shots a week, that's 100 holes in your muscles. That's 1,000 holes in your muscles every decade. You might be putting 5,000 holes in your muscles, and there's a lot of damage to that. One of my patients who was a cattle rancher told me where they stick the trenbolone in. He said you should see what the rump roast looks like on the inside where they're putting those pellets in. That really made me think about that.
Right.
The sub-Q is just so wonderful. It smooths things out. And
well, I mean, I agree. I mean, and that's why again, guys have to use, as Nelson, talks about, 27 or 28 gauge if you're on injectable. Well, one more layer to that question then. Do you vary the dose if sub-Q seemingly is more effective? And obviously, I wrote about it in the book, my book as well as I know it's in your book. Do you lower the dose?
What's that?
You lower the dose if sub-Q is seemingly more effective. Do you need to lower the dose and say a sip dose?
It's really a balancing act, because if a guy has low sex hormone binding, if you're taking 100 milligrams once a week,
right,
it's been shown to be the same as 40 milligrams twice a week. The reason because you're not excreting as much in your urine, because your serum androgen levels are not accelerating as much. You're not dumping as much testosterone in your urine. On the other hand, if you have low sex hormone binding globulin, you're dumping a lot of testosterone in your urine anyways. So you might split the 100 into 250s. It's really patient specific, again, with every single patient.
I don't like sub-Q. I actually got too many reactions, and I'm not bragging, but you have to have fat to have sub-Q.
Yeah, it's absolutely true.
So I use my shoulders. I actually inject 90 degrees to my shoulders.
Nelson and I do the exact same thing, by the way. I'm not big in injecting into my quads or my glutes at all. I like injecting into my delts or my tricep, that area, whatever. Another question I have is there an age limit, Dr. John, that you would consider if a man has never started TRT in his life? Is there an upper age limit that they should not consider TRT?
No, then I say the sooner the better.
Yeah. Then that question may come from the fact that some doctors may have already declined that person from getting TRT. There was one study that scared doctors done by Dr. Bassin that gave old men over 70 TRT, and they stopped the studies early because supposedly they had more cardiovascular events, not heart attacks, events. The events included rapid palpitations in some cases, hyperness, so included many things that may have been basically obscured by the data collection. So that study was actually scared some doctors. So some men especially over 65, 70, may find themselves being declined. So you would have to reach out to doctors that can manage and actually closely manage hematocrit, estradiol, cardiovascular inflammatory factors, blood pressure, water retention. But any man could feel great on testosterone if appropriately managed.
It really comes back to our previous conversation about how epidemiology is run, and that it boilerplates everybody. You cannot boilerplate patients. There are some surgeries that are really different. A plastic surgeon does not do the same procedure the same way every time. So you've got to customize the treatment. So you cannot boilerplate for a scientific study. You're going to have problems if you do that, because then you're ignoring issues that come up. Properly administered testosterone replacement therapy does not hurt people unless there's an underlying blood coagulability disorder. And that's going to come up in the first 30 days or so. And that's really quite rare.
And it's been determined that only 2% or less of men have that genetic mutation, which, yeah, it's been reported too. So any other questions, Jay? We're at 1 hour, 10 minutes.
Yeah, I'm scanning through. I don't see any. Oh, wait a minute. Okay, here's one. Okay, so here's a really good one. Hello, gentlemen. I'm something of an exception. I'm not a TRT user. I'm only 26 years old, soon to be 27. My natural test levels are around 800. I work as a personal trainer, educator, and writer within the fitness field. I think you guys know who this is. I work with older male populations a lot with my day-to-day profession. I have a very comprehensive, integrated approach to get people more muscular and healthy. I've helped Jay with some editing before his book release, and I have produced a lot of content on various topics. TRT is something I promote heavily to many of my clients, hence why I have people like Jay or Nelson or Dr. Osborne or Dr. Crisler use as resources. He's asking so for someone like him, when should he start recommending, like what age should a man be for him to start recommending, like as a trainer, to consider TRT? I mean, it's based on blood work probably, right?
Well, it's not a matter of recommending TRT, it's a matter of recommending an evaluation.
Right.
At what point does a guy need to get a look at by someone who really knows what they're doing?
Exactly.
But I would also say be careful with the word recommend. Unless you're a clinician, a physician treating patients, you should not be recommending anything to your clients. You should always have, say you go see, trained doctor to evaluate. But yeah, based on symptoms and blood levels, as we well know. And, like Dr. John says, I have too. In my 12,000 plus membership, I've seen guys in their 20s that have really low testosterone.
Right.
They didn't ever, the past men, especially young guys that have used anabolic steroids in the past, some of them may have shut down HPTA axis for a long time and for life sometimes. But sometimes I just see regular men that have not abused anything in the past in their 20s. So we're seeing more and more of those men. So, but anyways, yeah. Next question.
I think that's it. I think that's all questions. Let me just scan the board real quick. I think somebody just posted something. Okay, last question. I am on a weekly testosterone shot, and I administer it on Friday. I am taking 0.75 milligram anastrozole weekly. Which of the following is a better protocol for anastrozole administration? 0.05 milligrams on the third day after the shot, and 0.25 milligrams on, the third day after that, so that would total 0.075, or 0.25 every third day.
Well, I'd ask the guy how he feels on each day. Okay.
Yeah.
Some guys just need a little anastrozole on shot day. Some guys need a little anastrozole on shot day and then a few days later. Some guys need to be on it. I have had used varying doses throughout the week. It depends. Again, it's always patient specific. But when I talk to you about how you feel, I want to know how it goes on a daily basis after your shot. If you're taking, for instance, a once per week shot.
And most guys don't need anastrozole.
Yeah.
Okay.
I don't use. There's just one topic.
You just had to get that in there.
One last question, John, that you actually addressed earlier, and I wanted to hit. It's perfect because I wanted to ask it and I forgot. But when is the best time to take pregnenolone, and what is your dosage, your recommended dosage?
Most guys do pretty well. If you're talking about transdermal pregnenolone, 100 milligrams on the skin, it's wonderful for anxiety. If they're taking oral pregnenolone, it converts in the liver by the same enzyme that the finasteride inhibits, 5-alpha reductase. It converts into something that looks like a benzodiazepine in the brain. So I've had guys go stuporous on oral pregnenolone. You just got to kind of be careful and ramp it up slowly. But if it's a transdermal dose, generally 100 milligrams a day is more. Get 10%, 1 ml per day. Put it on the inside of your forearms. Rub your forearms together. Don't use your hands because it won't soak into your bloodstream. It'll just stop like a lotion because your palms are like leather. So, and that would be true of all transdermals, by the way. Don't use your hands, rub them in. Put them on the inside of your forearms, rub your forearms together, and then rub your forearms up and down on your flanks, on your sides.
You got this.
Hold on. There's increase. How about estradiol? Does estradiol increase on pregnenolone?
Not that I know of.
No, doesn't go down.
Here's the problem for engineers: is that this is not operational engineering. Is that things don't flow like an algorithm through the body. That there's so many complicated factors.
Don't talk down on me. I've been on this field for 30 years. I'm entitled to ask questions because I believe data is important. Anecdotal stuff, data. Anyway, so thank you guys on that note.
Thank you. I mean, honestly, John and I wouldn't even be here if Nelson wasn't who he is.
No. John has been around longer than me, and he's a doctor, so I'm not ever.
No. He's been around longer than you, but trust me, he's been a
doctor. I want to publicly thank Nelson because my book wouldn't have gotten out of it. So.
Yeah, we used to argue all the time. We still do, but we love each other. So
we all love each other, guys. It's totally awesome. And again, you're right, Nelson. Thanks for everybody. We actually had at one time we had 71 people that were watching live. So again, thanks to all of you guys out there.
And if you have any more questions, go to either excelmail.com or even post them on the comment section of this video down below, down there.
I have in all things mail form as well.
There you go. Yeah.
And then I guess kind of last thing is, guys that you're still watching, we still have a ton of people on. Nelson and I are going to try to do this once a month. We're going to have other doctors, other people inside the field of men's health. So if you have anybody that you guys would like to see on, again, just reach out to us and send us an email. We'll try to get them on.
Sounds great. Good night, guys. Thanks a lot.
Have a great night.
Bye, everyone.